screenings after this presentation. And don't think you don't know where you know, we're going to watch that for you. All right. You guys come on down to the front. There's plenty of seats down here at the front. This is not the spit zone. All right. So come on down if you're looking for seats. There's plenty of seats down here. It's a real privilege to introduce to you a good friend and colleague, Dr. Leonard Calabrese. Dr. Calabrese is a 1975 graduate of our College of Osteopathic Medicine. Subsequent to his graduation, he went and did his residency and fellowship training at a little place in Cleveland called the Cleveland Clinic. You might have heard of it. He's been at the Cleveland Clinic doing some major work over the course of the last 25 years to 30 years on an infection. Now, when I was following about 9 or 10 years behind Dr. Calabrese, we had this mysterious disease that was killing people, and it was killing them very, very quickly. And the call went out to academicians around the world to help us understand and manage a disorder that we later got to know as the HIV infection, and it was part of the acquired immunodeficiency syndrome. What a wonderful thing it is to have people in our profession who know how to step in because they have the tools and the skills necessary to combat a really terrible disease, and not just to combat it, but to come through with really revolutionary breakthrough therapies. That person who is responsible for much of that is the person that you are about to hear from. He's one of our grads. We're real proud of him. He's a wonderful friend and colleague, Dr. Leonard Calabrese.
It's a great pleasure to be back here on campus, and I heard a very nice presentation here prior to this opportunity. I was given kind of a free kick at the ball on what to talk about today, so I thought I would try to, I don't know, tell you a story that might be interesting. Talking about HIV disease, which to most of you is history. Most of you were born probably after the first cases were reported. But to me, it was probably the most pivotal thing in my career. It's taught me a lot of lessons, a lot of life lessons. You know, as opposed to giving you a science talk or something like that, I thought I would try to give you something that gives you some ideas and maybe provide some opportunities to you as you think about your career development moving ahead. How many in here are first year? And how many are second year? Well, that pizza really gets people to these talks. It's awesome. We do the same thing, so. Let me say that, you know, when I left school here, I really was not totally sure what I wanted to do. I wanted to do internal medicine. I knew that. And I had the opportunity during my clerkships to do some elective time, and one of the first people that I had the opportunity to work with was an immunologist. And I really didn't have any particular interest, and I certainly didn't have any background in it at that time, and it was a fledgling field. But I thought, this is pretty cool stuff. And this was pre-HIV work. And it was my intention to do adult immunodeficiencies. There weren't really that many. So you had to have a day job. So I tried to decide whether I'd do infectious disease or allergy or rheumatology. And I gravitated to do rheumatology. It's funny how life changes. So one of the lessons, one of the things that I'll tell you is that when you leave and you're going ahead, don't make any boundaries for yourself. You know, it's better to know the questions and the answers right now. Believe me. So I like to say that this is a talk, and it's really not a talk that I do a lot. I haven't done this for a few years. Talking about HIV disease is really talking about the most tectonic advance in science of our generation. this disease will be with us for the rest of our professional lives. But the breakthroughs that have come are earth-shattering. The application of basic laboratory technology to advancement of patient care, and you're clearly aware of this. I'll make I'll point this out. HIV has also done something else. It really is the driving force of medical professionalism as we know it today. And just listening to your CPC prior to this, and some of the language of patient autonomy and shared and informed decision making. A quick generation ago, this was not really as standard or as endorsed as it is today. When I say history of medical professionalism, I don't know how you learn professionalism in your curriculum. I'd be curious to know, maybe later on can find out. So if I asked you, if I went to a professional staff meeting at the Cleveland Clinic, which I do, and asked people, what is medical professionalism, I bet you I'll get a whole bunch of different answers. It's kind of like, I know it when I see it, but it's very difficult to define. Sometimes it's considered kind of a pedagogic and academic thing. It's discussed in kind of mythical terminology. But there's really some hardcore, and there's some principles that belie professionalism. How many of you have seen this document or have read this document or have given this document? It's called Medical Professionalism in the New Millennium, a Physician Charter. It's about a little over a decade. Has anyone seen this? So when this document was given to me, and probably about 10 years ago, it had been out for a few years, I had never seen it. It's endorsed by the American Osteopathic Association and about 100 other organizations. And I like to tell my students that this is like the 95% confidence intervals of professionalism. So just to give you a few words, and then when we talk about this epidemic, to go back and reflect on it, it's really it's a fabulous article, and you all should read it. It's written with what Dr. Sachs called chilling brevity. It's only 3 pages long. There are 3 fundamental principles. The principle of patient welfare. We are a patient-first profession. That's what we do. We're here for patients, and it's self-explanatory. Second principle is patient autonomy. We're no longer a profession of power over. We power with. That's how we treat people. And this, I believe, was born directly out of the epidemic of HIV disease. The third basic principle, and that's the principle of social justice. For too long, the medical profession has considered social justice a separate issue, and now it's forthright, and I'll give you some great examples of that. The commitments make sense. You immediately appreciate these, that we're committed to professional competence. Of course, I actually hate that word. Who wants their physician to be competent? Who wants to be great? I just want to be competent. Commitment to honesty with patients, truth-telling. That's what we do. We're, even at this point in time in your career, you're probably HIPAA'd to death and know that confidentiality is of paramount importance. You think that maintaining appropriate relationships with patients is an obvious and egregious breach, but in the state medical board, in virtually every state, inappropriate relations with patients is one of the leading transgressions, along with drug and alcohol use. We are continuously committed to improving quality of care, and in our health system, it's a huge enterprise. And this notion that we must commit ourselves to improving access to care. And that's actually pretty hard these days, because so many of us go into practice. You're not a private practitioner. You don't have a shingle and you decide what happens. You work for somebody and you provide access that they provide access to. So it's often a conflict. Commitment to just distribution of finite resources. Should everybody that says, I want a total body CT, should they just have it? Just because, they're curious to see what's going on? Or is there more to it than that? We are committed to scientific knowledge, and I believe that this, belies all our advances in medicine. And we are committed to managing our conflicts of interest. You can go on to my webpage at the Cleveland Clinic and you can read my conflicts of interest because they're public domain. It's not that I don't have them, they're just transparent. We are a self-governing profession, and that's what makes medicine. So let's go back and see how this epidemic came about. So, the beginning of it is the beginning, and this is it, June 5th, 1981. Just a handful of reports. This is MMWR, you're all familiar with this. Comes out every week, and said in two areas, on the West Coast and the East Coast, look at this, 5 young men, all active homosexual, that was the terminology that was used at the time, had biopsy confirmed when we used to call it Pneumocystis carinii. Now it's Pneumocystis yervecke. It was considered a parasite. Now we know it's fungus. Just a few small changes. But, and they said they had this infection that we all knew about. Pneumocystis was seen in people with bone marrow transplants and cancer chemotherapy and on heavy doses of immunosuppressives. These people didn't have it. But it seemed kind of odd because they were all young. They all had a certain shared lifestyle. And it was clearly a mystery. So the first question is, is this just ascertainment bias? Did somebody just say, I saw a patient, and then, people just happened to notice it by association? Or was there actually something here? 10 patients in a country of 300 million doesn't make it an epidemic at all. And so this was kind of tucked away. But it was dramatic because when people studied their immunology, they found that even back then, I always say that I went into immunology because I thought it was so simple at that time. There were only like T cells and B cells. I said, I can figure this stuff out. So they didn't have many T cells. And by that time, we had T cell subsets. There were like CD4s and CD8s. Now there's 265 CD determinants and over 100 cytokines. And we used to think that complement was the hard part of immunology. Now we know that that's the simple part. So times change, What are you going to say? Any rate, their cell-mediated immunity was depressed. They had very few T cells. So that was interesting. Yet, if you weren't in Los Angeles or New York, you didn't have the opportunity to see such a patient, and you just kind of tucked it away. Then, 5 months later, this man is traveling from New York to Chicago, becomes critically ill, comes to our emergency room, hospitalized in our unit, and immediately the team knows something is terrible. He's got whited out lungs. He has a bronch. They're pulling out pneumocystis. They're pulling out CMV. They're pulling out fungal elements. And somebody has the bright idea and says, I think this might be that disease that they talked about, in the New England Journal and the Annals of Internal Medicine, both here, and maybe this is what this represents. We had never seen a case in our institution, nor actually in the Midwest at that time. And because it was an immunologic disease, I had just joined the staff, and they called me and they said, I think we have this deal, and I'm not calling it AIDS because that really was not the name at the time. This immune deficiency seen in homosexual men. That was the terminology at the time. And he's got multiple opportunistic infections. And do you want to see this patient? Is that your business? Is this infectious disease business? I mean, we don't know. And I can remember being on the phone and thinking, should I go see this patient or should I turf this off to the ID guys? I mean, they told me how many infections that they had found already. And I just had this feeling that I should go see this patient, and I did. And I went. I was totally blown away. And as you can see, these bruises here. These are not all bruises. These are Kaposi's sarcoma. So this poor man, who I never got to meet because he was already on a ventilator, had multiple OIs. This is HHV8 causing Kaposi's sarcoma. He had 11 opportunistic infections at postmortem. And my prophetic words were, okay, I said, this was pretty fascinating. If we ever see another patient of this, call me again. Because, there's a saying, there's no guilty snowflake in an avalanche. Who knows you're in an avalanche? You're just a snowflake. You're seeing one patient, there are 10 patients reported. You have no idea that this is the beginning of the most formidable epidemic in modern history. But it was. And so many, many months went by without seeing another patient. But we became interested in it. Within the next year or two, this captivated the attention of the country in a very salacious way. And you can see from some of these headlines, this is Life magazine, no one is safe from AIDS. Okay, at that time, when this article was written, there were probably hundreds of patients reported. Not thousands or millions, hundreds. So the fear of the disease was traveling faster than the disease itself. A very famous actor of a different era, Rock Hudson, developed this, and this was actually seeing someone that somebody could recognize, a face that could be recognized, had a very chilling effect on the society, and so it had a connotation to it that was something between being kind of twisted and being unusual and being kind of scary. Now you think, how would that translate to you being a physician? The notion of physicians and plague is not, by any sense, a modern one. And as you can appreciate in history of medicine, history of medicine is here to teach you not names and dates and historical stuff. It's to teach you relevance and to teach you perspective of mistakes made in the past. These are the plague doctors. This was, Venetian design, and they would put rubbed leaves in here because it was believed that disease transmitted through, the ether, and smelling the stuff would protect you. Interesting. These are some headlines from the Cleveland papers, 1983, calling it the gay plague, highly pejorative, drumming up great fear and recrimination. And this is not social justice. So these early cases were highly personal. Healthcare workers took different stands. In my own department, in a department meeting, one of my colleagues said, "You have no business taking care of these patients up here. We do not understand this, and it's not safe." And we had a discussion. There were healthcare workers in our town, and we're in the Midwest, and we're not even in the mainstay of this, that chose to leave major institutions. There were people that burned their uniforms in the parking lot. There was an anesthesiologist who said, I'm leaving town because I don't want to be in a city that takes care of AIDS patients. So his answer to this, to the problem here, was to move to Indianapolis. So he, you know, I mean, I'm demonstrating very small thinking here, you know, like, oh, I'm going to go 100 miles down the road. It's never going to be there. So, you know, how silly can it be? But like I say, we were all just snowflakes at the time. People who did care for these patients and nurses who cared for them and cared for people lovingly and personally were really early heroes in this. Anyone ever heard the name Carlo Urbani? I'm sure you haven't. This is an old slide. Carlo Urbani was an Italian public health worker who was working in SARS epidemic more than a decade ago. And he stayed at his post in Southeast Asia and acquired SARS, caring for people, and died. And just shows that, you know, these things still come about. So what was really different at that time was that we could make a diagnosis of this, but we had no virus. Actually didn't know that this was animal, vegetable, or mineral. You knew that they didn't have CD4 cells. You knew that they had lymph nodes. You knew that they had these opportunistic infections. So you had thrush and this and that. And people would come in, and you see young men, MSMs, who had all of these stigmata, who had no CD4 cells, but you had no blood test. And all you could do was say, you know, I think that you have this condition. And there were many names for it. GRID, gay-related immunodeficiency, lymphadenopathy syndrome. Multiple terms were used. But comfort was really all that you had to offer. And at that time, people were dying, you know, in a hurry because there was no therapies, minimal prophylaxis. Anyone know the name? I know it's a big crowd here, and I don't usually talk to big crowds of students like this, but Ambroise Paré? They raise their hand? No Google allowed? Ambroise Paré, famous French battlefield surgeon of the 15th century who wrote the definitive textbook, but his famous quote was, you know, we cure a few, we help many, but we comfort all. This was a Paré moment for sure. But other people had said the same thing. Francis Peabody, for which there's still a Peabody Society in Boston, great physician and great humanist, one of his famous quotes that I use frequently and reproducibly is he said, the secret of patient care is the care for the patient. So even in the absence of an etiology and specific therapy, there was care to be administered, and it was done. There was huge rejection. So people didn't want to come in. Why the hell would you want to come in? Why would you want to go to the doctor, find out that you probably have this disease that they can't name, that people will now treat you shabbily, there's nothing to be offered, and all we want to do is take your blood and study it. And we did. You know, we didn't understand it. Dr. Michael Letterman and I have been colleagues in this for almost 35 years. We went out in the streets. We rounded up 500 men who had sex with men, brought them in, interviewed them, did basic epidemiology, physical exams. We bled them, stored their blood, stored their cells. This was the beginning of research in this area when we didn't know much. Cultural sensitivity. Who knew? I mean, you know, there was not a systematized way to take care of people of alternative lifestyle. You know, we talk about gay, lesbian, and transgender people now in a very forthright way. Most of us, virtually all of us, really were not schooled in the least, and we had to develop our own sense and sensibility of how to go about this. We were called in to do things. In Lorain, Ohio, I remember this very well. I just made a note of it, that a young hemophiliac girl with HIV, beautiful little child, was castigated and thrown out of school and told never to come back. And I went to a town meeting that seemed more like the Salem witch hunt than anything that you would want to think about. So there are all these issues. And so for a person like me, this was an incredible opportunity to grow. I didn't know anything about public health at the time. I was just a immunology guy. But it provided an opportunity, and working with governments and working with public health and working with the mayor, and it was an example of asking myself a question: should I be doing this, or should I be focusing on something else? So no boundary. Then it's all over. Here it is, 1983, 1984. This is Robert Gallo, who didn't win the Nobel Prize, Luc Montagnier, who did win the Nobel Prize, and the Secretary of Health announcing that they had found the etiologic agent. It was a human immunodeficiency virus. It was called by a couple different names. And they promptly predicted that there will be an effective treatment within a year, and there'll be a vaccine in 2 years, and go home and rest easy. These are the things that happen in medicine, and they happen today. People say things that have no basis in evidence. They're not evidence-based. All right, I want to shout out here. This is a quote: "The philosophies of one age have become the absurdities of the next, and the foolishness of yesterday has become the wisdom of tomorrow." You don't have to know where that quote came from, but think about it. It's as good now as it was 100 years ago. Who's this guy? When I asked this at the Lerner College, somebody said Colonel Sanders. He is not. He has societies on every continent that worship and revere his history of professionalism. He wrote a leading text in medicine that lasted for 45 years. He lived in 3 countries that all claimed him as their own. And he's the master and instigator of bedside teaching that you all have advantage of. Just come on now, shout out. Who is this? Osler. Sir William Osler is the man, and he spent his bulk of his career at Hopkins, and he did all of that. We'll come back to him again. So there was a drug that came out, AZT, and anybody that sees Rent, movie or the play, you get this. This was the deal. The medicine came out just like they predicted, but there was only one problem. It didn't work. I mean, it did work. It suppressed virus, raised CD4 cells by a nickel's worth. You probably got a few extra months of life. It was highly toxic. This was not the home run that was predicted, but people wanted it and lined up for it, and people couldn't get it. You had to be in a clinical trial. You had to meet all these criteria. You had a disease you knew was totally fatal, and you knew it was available. You didn't know it was going to be ineffective as it was, but what kind of existence would that be? How would you feel as a patient? Autonomous or power under? Really power under. And this was the beginning of the empowerment of patients. I see at the airports today pink ribbons and things like this. That did not exist before HIV. Did not exist before that. People with diseases didn't group together to empower themselves. And if nothing else happened, this did happen. And there is a champion of this that's still on the national scene. That's Dr. Anthony Fauci. You see him on the evening news. He's the guy that brought patients into the dialogue about their own disease. So every disease safety monitoring board, all of these governmental agencies, all now have patients that advocate. A cousin of mine who has HIV and has had it for, I'd say, close to 30 years, has testified in Congress more than half the politicians. So there are a lot of community efforts going on. You don't know any of these people, but there is a Dr. Paul Volberding, who is still on the scene, head of the International AIDS Society. It was him when he was just a young guy. Merv Silverman was the first public health director in San Francisco to confront this and close the bathhouses because there were, issues of what should be done. So there are a lot of things going on that were highly controversial. The blood supply. I can remember sitting in New York City and hearing Dr. James Bovey, who was the head of the National Blood Bank Organization, say the blood supply is totally safe. Totally safe. This is not transmitted through blood. This is back in the early 80s. I mean, everybody knew that was bullshit. And, but there was no test. They said, well, they're getting it from other lifestyle things. And so when it becomes totally transparent, when the laboratory tests came out, people were discredited tremendously. I can remember when the first blood test was developed and we had access to the reagents and we did the test. So I heard talking about tests. So, one of the things when you're calculating the sensitivity and specificity of a test, sensitivity, the number of people with a disorder have a positive test, specificity, the number of people without the disease who have a negative test. So it was just an ELISA, but nobody knew where to draw the cut point. So if you drew it down here, there were several of us that were positive. If you drew it up here, there are some patients who didn't have it. And so, taking the best guesses early on, the chairman of infectious disease at Case was told he had a positive test. And he didn't. But at that early cutoff level, he did. There was no Western blot. There was nothing. It was terribly frightening to people, incredibly frightening. And as much as there's frightening, there was anger. They're angry they couldn't get into clinical trials. They're angry that people were lying to them. And who saw Dallas Buyers Club? All right, let me tell you about that. I didn't want to see it because I said, this is my thing. I mean, that was my era of doing this. I saw it. Besides weeping on the plane like an idiot, probably people thought I was having some kind of panic attack or something. That was so accurate. That was so unbelievably accurate. A few little things here and there, but it was amazing. And people did this, and people would bring back drugs from other countries just to do it because, there was no alternative. I was at an international AIDS meeting sitting next to Dr. Fauci in the late 80s. When the venue was attacked by a bunch of activists, stood up on the table, smashed the glasses and the pitchers. A woman named Margaret Fischel, who was a very prominent researcher, was there. They came and did this scene out of Carrie, poured a big thing of something that looked like blood over her. And this is the real deal. And so, it was more than just trying to figure out a problem or do a CPC. This was life in the raw. And you learn from that, and I did. This was the saying, silence equals death, knowledge equals life. People wrote about it. You can still read this book. Randy Schultz was a friend of mine. He died of HIV. He was a councilman. He wrote for the San Francisco Chronicle at the time. So it was made into a movie. there were moments in time that were pretty crazy that this seems like nothing. What is she doing? She's shaking this guy's hand. That didn't happen. That did not happen. In this country, this guy, he had never even uttered the word for 8 years that he was a president, never said HIV or AIDS. Nothing. And let people, it was not a good scene. So there's another era. Now drugs started to come out. And people weren't dying from pneumocystis because we could prophylax from them, but they died of this stuff. This is call this the second phase. This is the era of untreatable opportunistic infections. So I already told you what this is. This is KS, it's HHV8. Anybody take a guess what this is? It's a good guess, but that's treatable. So this is an untreatable thing that presents in their brains. It's a syndrome called progressive multifocal leukoencephalopathy. It's caused by the virus JC. Half of us in this room are infected with JC, and about a quarter of us will be peeing it out when you go to the bathroom. But it is, in an immunosuppressed patient, it is a very rare disease and a subject of my research in later years. It's another story. And this is CMV retinitis. At one time, I had dozens of patients on active home IV antimicrobials being treated for this. So this is a different era. We couldn't pound the virus down. We could prevent some of the infections, but people died from other ones. It was now the leading cause of death among Americans, 25 to 44. The leading cause. I mean, not like moving up on the list. This is what people died from when you were young. I felt that this was the most difficult period because we knew what the problem was. We had these terrible drugs that in our heart of hearts we didn't really think were doing much, and it seemed like false promises, loss of faith in research, all this energy. You know, we were supposed to have a cure in a year, a vaccine in 2 years. It's gone 10 years before. So we had to move on. Yet at the same time, there were heroes. Ryan White. Ryan White was a hemophiliac in Indiana that they tried to burn his house down, and was an advocate. And now we have the Ryan White bill. And in every city in the country, Kansas City, there's Ryan White funds for patients who don't have access to treatment and care, and it's fabulous. Great activism. Instead of just being angry, it was constructed. And the most moving thing that I had seen ever was the quilt. One section for each person. This is the Washington Mall, and that was only just part of the quilt. Just people were dying, but we were taking time to memorialize and to revere their memory. And we still display parts of the quilt from time to time. It became part of our culture. Philadelphia story is really good. Rent. Now we have Angels in America. Larry Kramer, big HBO documentary on the guy. A lot of things came about. I learned something else that maybe this might be instructive to you. You think that you're going into medicine, you're going to be a practitioner, and people will ask you, well, what do you want to do? Do you want to be an academic? Do you want to be teaching? Do you want to do? And sometimes there's this notion like, well, I'm going to go into practice. I'm not sure that I'm going to be able to engage in any of that. And that's just not true. So there's a great book. I'll give you another recommended book. How many of you have read anything by Atul Gawande? All right. So he has a book. One of his books is Better. And it's just about how to make yourself better. And these are things in your profession. And he has these admonitions. And one of them is count something. And what he means by that is reflected in this third phase. So here's our man again. And he said, so there's a book that I give out to people that rotate on my service called The Quotable Osler. It has almost 900 quotes by him. And you can get it on Amazon for a couple bucks. I recommend it to you. Always use it. He said, the value of experience is not seeing much, but seeing it wisely. He said, a man who has seen 500 cases of pneumonia may not have the understanding of the disease that comes from an intelligent evaluation of a score of them. In other words, measuring outcomes. It's a common error to think that more a doctor sees, the greater his experience is and the more he knows. It's only if you use it wisely. So one of the things that we think about with this is it would be a crime if at the end of your career you said, I've taken care of 4,000 diabetics, and you can't tell me anything about that. Now with electronic medical record, we're able to better capture that. So people are able to take observations and do things. So I saw a patient in the 80s, because I was doing this rheumatology stuff and trying to do all this HIV stuff, that had rheumatoid arthritis before they got HIV. And HIV came, and then after a few years, this patient became CD4 depleted, and the rheumatoid went away. I mean, there was no signs of this rheumatoid. At that time, we didn't have very good treatment for it, so this was quite remarkable. So reported this, found some subsequent case reports, and actually worked with a biotech company to develop one of the first biologic therapies in clinical trials for this disease. It was an anti-CD4 monoclonal. The CD4s went away, the rheumatoid went away, then the rheumatoid came back, but the CD4s stayed away. It was bad, so it never went further than that. It was very toxic medication. But it was an example of an observation that could lead to a trial. This was also written, the senior author was Ray Tubbs, who just died in the past year. He was the first DO staff guy at the clinic. When he died, he had over 600 peer-reviewed publications. Professor of medicine, one of the great figures in immunopathology in the country, and a dear friend of mine. The other notion I had is that since I'm a rheumatologist and since I take care of HIV, maybe we should just assess the rheumatic symptoms of our patients and follow them over time. It's not very gratifying. So you start out, you got 25 patients, 50 patients, you collect all this data, you assess them. Maybe one or two people has something, maybe somebody doesn't. But I started doing this in 1987 and was still doing it in 1997 and created the largest longitudinal cohort of its type because you're counting things and keeping systematic tracking of them. Had great biostatisticians and great people to work with, but these are things that you can do without a laboratory and are meritorious. By 1997, we started to use drugs in combinations, and that's when protease inhibitors came out, and the death rate from this disease plummeted. Also, instead of having to take this, people could now take this. And now there's a handful of one-a-day drugs. So it's now not a mystery, it's a ground war. People that have HIV have a lot of drugs use, of intercurrent mood disorders. We have to do it. Probably the greatest opportunity that I was given was to manage and orchestrate the first cardiac transplant in an HIV patient at the Cleveland Clinic, which was the first cardiac transplant in an HIV patient in the world. And so we had to assemble a team. We took a patient who couldn't be done at any other institution. No one would do it. We did it. This was published in the New England Journal, and represented, such a tectonic advance in science. I already told you 20 years earlier, you couldn't do anything more than give somebody a hug. Now we're transplanting their hearts and doing pretty good. So that was pretty cool. And now we're into the fourth phase. And the fourth phase has two different pictures. It's old world and new world. In the old world, most of the cases, as you're well aware, are sub-Saharan Africa, and this is the epi. And up until George Bush was president, there was virtually no antiretroviral therapy there. Regardless of what you think of him and his presidency, the guy gets total credit for expanding HIV care into underserved African populations and other third world. The 4x4 program was fabulous, highly successful. Millions of people came on it. They took people that had this and turned them into this with what we originally called highly active antiretroviral therapy, or HAART. A friend of mine from Cleveland coined that term. Now we call it combination ART, CART. Now there's over 7 million people in Africa on these medications, and making them affordable by bypassing much of the drug company stuff. So this is the new era. People don't die of uncontrolled virus now if they have access to the medications and they take them. They have good adherence, great adherence. You can wipe the virus out. So what do people die from? They die from advanced end organ disease. Heart disease, lung disease, kidney disease, liver disease, and metabolic complications. This is what patients on some of these medications, not so much the new ones, but cause fat atrophy, subzygomatic fat loss, mitochondrial toxicity. And what they really cause, and I just spoke at a postgraduate course and an international meeting at Johns Hopkins called HIV and Aging. And what HIV causes is premature aging. And if you know this topic at all, your immune system, like every other system in your body, bones, muscles, cardiac, central nervous system, everything tanks when you get older. It's already tanking in you guys. To age is to rot. It occurs much more rapidly in patients with HIV, and your immune system undergoes senescence. In them, it's undergoing senescence much more rapidly. So this is a forefront trying to figure out why people age, and to develop anti-aging strategies uses HIV as kind of like an accelerator for study. Okay, so lastly, I'll give you another book. Abraham Verghese. Who's read anything here? Who's read Cutting for Stone? All right. Hey, you guys got to start reading. I know you got a lot of stuff to read. I've been there, done that. I know. But, okay, so one of my my fellows, when I was a resident, he says, Calabrese, what are you reading? And I'm like, what do you mean? He goes, what are you reading right now? And I said, Harrison's. He goes, no, what are you reading? And I said, nothing. And because I'm too busy, I'm trying to read for this stuff, take these tests and all this stuff. And he said, that's not the way to develop. He said his role model was that, yeah, you do. And he was the smartest guy that I had ever met. He knew more medicine than anybody. It wasn't like he was slacking. He says, you read two things at the same time, in addition to your medicine. Because read something that's pulpy, that you enjoy, it's easy and light, and then read something significant. Read something that's nonfiction, or read a classic, and just keep them going. And I adopted that very early on in my training, and I've tried to do that now. In the e-reader thing, it's fabulous. Carry your whole library. So there's no reason that you shouldn't read this. My own country, anybody read that? This is the story of him coming to this country. He's an ID guy. He was sent to underserved area in the Appalachians at this time in HIV in the 80s. Just what I told you. And his story is my story, except for written by a guy that has the pen of an angel. When I read this, it just totally blew me away. And we do readings from that in our some of our seminars. It's a fabulous thing. So this is the actual history that I've told you from 80 to 2000. It keeps going out. It started here, the first cases, confusion, despair. The drug came out, sense of usefulness, personal fulfillment, burnout, that terrible period where, just things were not going right. Now, heart comes about, medicalization moving forward. So what does this actually tell you? The early phase of this disease is what the physician that wrote this called the compassionate-based work ethic. You had nothing to give other than compassion. And the later part is competence-based work ethic. You now do molecular monitoring, 35 drugs available. It's very complicated, and primary care physicians really don't have a role in managing that aspect of it. But you don't want one or the other. The whole deal is you want both. And that's the end of this story. And you want to be more than competent, but even when you're competent, you want this to be in a basis of caring. So, on the one hand, if you're just a caring person, well, you be a social worker. It's great. And if you're just competent and, some kind of superstar guy, you could be Mr. Spock and have a tricorder and do this. You want your physician to be complete, to be a person in full that can, listen deeply, be mindful at the bedside. That guarantees you that you administer better care, and I guarantee you better caring. At the same time, got to be on your game. Nobody can be better than you in terms of critically appraising data, moving yourself ahead. So that's the story. So if I condense it to some of the things that I told you were things to make you better, is to, really have no boundaries. Count something. You can start counting right now. Do great projects right now. Two other thoughts for you. This sounds a little preaching, but don't complain too much. We in our profession, your profession, my profession, doctors are really good at this complaining thing. And we're so privileged. We are so privileged. And it is very easy to go sit in the, what somebody, one of my colleagues calls the fat-ass doctor lounge, if they still have those things. And when everybody's complaining about their schedule and their reimbursement rate and all this stuff, it really doesn't help this, and it drags you down. It's better just to shift the attention away or just go do something else. Doctors are very good at bravura, confident thinking. They're not quite as good as humility as we think that we need to be. So a positive attitude is that's how I pick people to be my fellows and my colleagues. And the last thing is, ask questions. And that could be everything about science. Take the Oslerian maxims that, a lot of the stuff you're learning today is just a bunch of baloney. And a couple years from now, you'll realize it. Or it could be ask a question to your patient. Who are you? And, you're not the Kaposi sarcoma in room 6B. You're somebody that, somebody's son, somebody's father, something. Also, you can ask a question to those people that when you get in the hospital and you're on the wards and you're sitting down and there's a nurse or a mid-level provider that's doing something, ask people who the hell they are. And not only that, ask one more question. Like, I'm Len Calabrese. I'm from Erie. Yeah? Tell me about Erie. Where'd you go to high school? How did you get into this business? It's a miraculous thing that's at your fingertips. All right, that's all I've got to say. I'd be happy to answer any questions. This isn't procedural knowledge, and this isn't any kind of no test for this stuff. But thanks for your attention.